way.
Ready to do this? Yeah, you're the
Yeah,
big, you're the big guy. All right, friends. Hopefully everybody can hear me out there today. I'm Brad Thrash, one of the pediatric endocrinologists here, and it's an honor to introduce Dr. Ryan Dyess. He is our graduating fellow. He is the first fellow ever, well, I don't know ever, but he's the first fellow in the pediatric endocrinology program in quite some time. He did his undergraduate education in Nevada, at the University of Nevada in Reno, Nevada. I think I pronounced that correctly per him.
you got it.
He did his medical education at Ross University. He did his residency at the University of Tennessee in Chattanooga. And then he is completing his fellowship with us in a few months. And then when he leaves us, he is going to South Carolina. He's taking a clinical job in Greenville, that's affiliated with the University of South Carolina. And during his time here, he has done quite a bit of research in diabetes, especially in youth living with type 1 diabetes. And his big project had to look at CGM accuracy in this specific patient population. So please welcome him, and we look forward to hearing what he has to say. Dr. Dyess, it's all yours.
Thank you. Dr. Thrasher had mentioned that he was going to do like a big announcer thing, kind of like because I was from Nevada, kind of do that, that big announcer who does the UFC fights. So I don't know what happened there. Maybe he got a little gun shy, but I appreciate the introduction. As he mentioned, I'm Ryan Dyess. I am the ASPGY6 or graduating endocrine fellow, unless somebody tells me otherwise sometime in the next 2 months. And I'm here to talk about my research project, which is entitled, really long, CGM accuracy during exercise in youth with type 1 diabetes mellitus. But before I get too far along, I want to do some special thanks here. First of all, thank you to the entire department, first of all, for just guidance through fellowship, but then also allowing me to recruit patients out of your clinic. Obviously, I had to interrupt some of your clinic visits and say, hey, do you mind if I come in and recruit this patient for my study? So I appreciate you all being real flexible with that. Additionally, some individual thanks to my SOC members, Dr. Brothers, Dr. Sullivan, and Dr. Watson. Thank you for your guidance through all of this. And then all of the individuals who really were helpful in the day-to-day aspects of this project and really made it a reality. Tim McKay, who's our exercise physiologist, who really, this was kind of his brainchild as much as it was mine. And then Jana Fagan, who helped out with some of the statistical analysis over in the cards department. Dr. Wintergers, who's helping out with some manuscript review and just how to really navigate the system. And then obviously Dr. Thrasher, who is a mentor and has been my mentor through this project, but is really a friend and my running buddy, even if he's half a mile behind me most of the time. So now that we've given some thanks, the obligatory slide. I'm not making any extra money. If you can figure out a way that I can do that, I'm still interested. I'd love to figure it out. So quick outline, we're going to talk a little bit about exercise and diabetes. I won't belabor it too much because that's exactly what I talked to you guys about a year ago. There will be just kind of a few slides that I'm going to touch on again, just so we remember that and it's fresh in our minds. We're going to talk a little bit about glucose monitoring because obviously this is talking about glucose monitors. A review of some of the literature that I found, what I did in my current study, the results, and then finally we're going to talk about use of CGMs during exercise and kind of what we should be doing going forward. So, a little background. Remember, exercise and diabetes go hand in hand. It's really important for individuals with diabetes to exercise. And I think this quote, which is exactly the one that I led with a year ago, summarizes it really well. The adoption and maintenance of physical activity are critical foci for blood sugar management and overall health in individuals with diabetes and prediabetes. And this is from the ADA position statement. Going over the specific recommendations for individuals or adult individuals with diabetes, they should be getting at least 150 minutes weekly, at least 3 days a week. So you can't just go for, a marathon run once a week and call it a day. Resistance training 2 to 3 times a week. Trying to incorporate some flexibility and balance training, particularly for older adults. Walking a little bit extra to get to the store, taking the stairs instead of the elevator. And then if you can do a supervised training program, that's even better than just nothing, no supervised program. For kids, it's just a little bit different, but not overall too much different. Goal is 60 minutes a day of exercise. This can be just free play or doing more organized sports. Vigorous muscle strengthening exercises 3 days a week, really similar to the adults, and then decreasing sedentary behaviors. Again, walking a little bit more, not sitting in front of a screen all day, watching TikTok videos. However, with all of this, and we reviewed this last time, there is a risk of hypoglycemia because exercise can induce rapid fluctuations in blood sugar. So remember, I presented on hypoglycemia risk actually for a decent amount of time during that talk last year, and I won't belabor it all. But there was that focus on hypoglycemia because it is important. It causes barriers to people performing exercise and really inhibits some people and makes them scared of exercising. In 2008, the DirectNet study group, or Diabetes Research in Children Network, found that during exercise, particularly aerobic exercise, there's frequent hypoglycemia if you had a blood sugar that started below 120. Obviously, you're going to decrease quite a bit with that, but hypoglycemia is common, and it includes after exercise as well. So that brings us to monitoring glucose. It's really important to have an accurate measurement. We've come a long way from when we were peeing on sticks to see what is my glucose, how much insulin should I give. We introduced glucometers so you can actually check capillary glucose measurement. This one's a little bit near and dear to my heart because when I was diagnosed with diabetes at age 9, this is the one I was sent home with. One touch two took 45 seconds, and I would run around my house and see if the rest of my family wanted to place bets on what my blood sugar was. I won most of the time. But since that time, blood sugar technology has continued to be revolutionized. We've got smaller meters. They don't take 45 seconds. It'd be really hard to take the bets for all this. Again, someone from Nevada here. Betting is kind of in my DNA. But then in 1999, there was the introduction of continuous glucose monitors. And the one pictured here is, anybody that's in clinical medicine knows is the Dexcom G6. And these devices are attached on top of the skin and have a little catheter that sit in the interstitial fluid. And they obtain measurements and tell you what they think the glucose is. And since first being introduced in 1999, the technologies continue to improve and continue to improve. And now, as anybody in clinical medicine knows, they are approved for use without finger sticks. You don't have to calibrate this device. So many individuals with diabetes aren't really checking their blood sugars on a regular basis. Which leads to the question, how accurate are these CGM systems while you are exercising? I mean, goodness, we're looking at these all the time, and personally, I basically rely on that all the time. It's not very easy to bring a glucometer with you while you're running, say, and stop and check your blood sugar. So you just look at the thing and say, oh, yeah, my blood sugar's fine. So we have a fantastic program called the Christensen Family Sports and Activity Program to help our patients with diabetes understand how exercise will affect their diabetes management and help them improve the management of their blood glucose during physical activity. During some of these assessments, our wonderful exercise physiologist, Tim, who I mentioned earlier, began to notice some discrepancies between what the CGM was saying and what the patients were saying they felt their blood sugar was. They're like, goodness, I feel really low, but my CGM's saying that my blood sugar is 100. And then they would do a capillary glucose check with a glucometer, and sure enough, they were below 70. So he was like, what's going on here? Is there something that we're missing? So he started asking me a little bit about this, knowing that I had type 1, and I was like, goodness, I rely on my Dexcom all the time when I'm out running or doing a bike or whatever it is. And I guess I just follow it, and when it starts, looks like I'm going down, I'll eat some more and just kind of get back to it. But the symptoms of hypoglycemia and a good workout kind of overlap. If you think about hypoglycemia, you can have some sweating, a little bit of jitteriness. Maybe your heart rate elevates a little bit. When you're getting a good exercise in, I hope that you're getting some sweat. That's what we want our patients to do, is work up a sweat, which means getting their heart rate up as well. So some of these symptoms can be masked by exercising. So I was like, goodness, I don't really know. Additionally, as we all know, these systems are used with closed loop systems. The CGM integrates with the pumps and makes adjustments based off of what they predict the glucose is going to be and what it is currently. So there's been multiple studies that shown, during exercise, closed loop has worked great based off of the CGM technology. But if we're relying on faulty readings or they are not accurate while you're actually exercising, are these studies a little flawed? Are they not bringing or preventing hypoglycemia as well as we think? So that brought me to a literature review. And again, I didn't want to become Bill Murray and just do the same thing that somebody else had done previously. If anybody doesn't know, this is from Groundhog's Day. Does the same thing over and over again until he breaks the cycle. Fortunately, while I was actually doing my clinical research and recruiting people, a review article came out summarizing a lot of these articles that I had looked up. So this was published in the beginning of 2021, so just about a year ago, in Biosensors. And overall, they mentioned the statistical results confirm that CGM during exercise periods is less accurate. Additionally, the review article noted, and I quote, "More modern sensors are expected to be more accurate during periods of exercise. However, it was found that very few studies for exercise have been done using the latest generations of sensors to our surprise, because most of them have been done on Dexcom G4 Platinum and the Paradigm VO and all of those." So looking at some of the data that they got from that study, down below is just each one of the individual studies, and then it looks at what the change in the mean absolute relative difference was. So the difference between what your glucometer reading was, or YSI, Yellow Springs instrument, and what the CGM was saying. For YSI, it's denoted in red over on the left side of figure A, and blue is with just a blood glucose machine. And you notice that everything that is going in the upwards direction means that there was a increase in the MARD during activity. So there was several that did decrease over here. The same figure is over on the right-hand side, and it just delineates it by what type of exercise they were doing. So purple's resistance exercises, which as we reviewed last time, changes your blood sugar not as much. And I'll bring up that slide here in a minute as well. But the aerobic ones is in orange, where you see much larger changes in the blood sugar or in your MARD. Then the green is high intensity workouts, and then blue was intermittent exercises. This is some more studies. These are ones that didn't have MARD at baseline. So before the exercise period, they didn't get any baseline studies. So they just based them off of what the MARD was from other studies outside. But again, looking at the YSI versus the capillary glucose, and then the aerobic, you can see was a lot more or a lot larger changes in the MARD. Looking at some of these studies individually, in 2016, Talib and colleagues investigated the accuracy of both the Dexcom G4 Platinum as well as the Medtronic Paradigm VO. And I have the mean absolute relative difference, the MARD, highlighted there so you can kind of focus on that. I know that it's a little small. Hopefully everybody can see it. But they enrolled 17 adults and had them exercise for an hour each visit. It didn't exactly say what the exercise was, but they had participants perform 2 different types of exercises during their different visits. And during their study, they noted that there was an increase in the MARD from 13.5% or 13.77 to 22.53. So you got significantly worse for the Dexcom G4. And then there was a similar increase for the Medtronic Paradigm VO from 12.38 up to 20.44 in your relative difference. Similar findings were found in 2018 when Biaggi and colleagues noticed an increase in MARD from 9.5 to 16.5 for the Paradigm VO during aerobic exercise. They had them do cycling exercises of 15 minutes, and then they would take a 5-minute break and then go 15 minutes again, 5-minute break. So I circled the P0 and the P1 because they also looked at how accurate it was after they finished the exercise. So the MARD increased, as you notice, it's the one right before the N, from 9.5 to 16.5. But then if you look at the rest of the line, it actually improved after that, which is important because it's something that our study showed as well. But during the exercise, it did increase. Yeah, absolutely. It's a question.
The did plasma glucose, right? That was done at a single time. Then this value is
so they were looking at multiple points. I believe it was each hour afterwards. So they did time right when they began the exercise in this particular study. P1 was at the end of that 60 minutes of exercise. P2 was an hour after the exercise was over. 3, 2 hours after the exercise was over. 4, 3 hours after. And 5 was 4 hours after. And then they would be done with the study and went home. So it's yes, just one measurement. They didn't take multiple sticks at that time, if that's what you mean. Yeah. So in 2019, the Havria and colleagues looked at the Dexcom G4 Platinum as well as the Dexcom G5. So looking at Dexcoms here. They did 17 adults doing aerobic exercise consisting of 1 hour of walking or light jogging on a treadmill, which is similar to what we ended up doing. And the activity was broken down into 4 15-minute bouts with about a 5-minute rest in between. So similar to the previous study where they were doing cycling. And they reported CGM lag times. So the reading just lagged behind what the capillary glucose was saying by about 8.2 to 14.8 minutes, an increase in the MARD from 8% to 13%. But there was, about an average of a 10-minute delay in what your actual glucose was supposed to be. So recently, actually while I was doing my study, another study published in 2020 by Dyess and colleagues looked at the Dexcom G6 in adults. This was done out in Oregon at OHSU. And they actually noted acceptable clinical accuracy with a MARD increasing from only 9.5 to 13.3 during aerobic exercise that was limited to 30 minutes. What they had was individuals doing home workouts that were on like a video. So they would send them, Beachbody on demand or something like that and have them do a 30-minute workout. And during these workouts, they would check and see what the glucose was over time. You can see that, I know it's pretty small, but this is time 0, and this gray bar represents while they were exercising. And then they got measurements every 10 minutes, and then for up to an hour afterwards. They spaced it out to 15 minutes after the exercise was done. But it only increased from 9.5 to 13.3. So that was promising that maybe as the newer generations are coming out, that they have better accuracy. Lastly, the last one that I wanted to go through was an article that was published in 2019 by Steineck and colleagues who looked at the accuracy of different CGM placements. Now, in adults, it's only FDA approved for use on the abdomen, right? In peds, it's actually FDA approved for abdomen as well as the buttocks. I don't know why they're not trying to do any more placements because we all know that we wear them in more places than just the abdomen. But they wanted to look at arm. Correct. The Libre you can use on the arm. But for some reason, the Dexcom only approved for use on abdomen. Although it is approved in the UK for use on the arm. So interesting. Yeah, absolutely. That's where I personally use it. So they looked at the arm versus abdominal placement in normal day-to-day settings. So just kind of like, hey, you're doing everything. And as a part of their study design, they had participants exercise for 45 minutes of cycling and reported the MARD as well. They didn't notice any difference in the MARD between the two sites, so whether you were wearing it on the abdomen or versus the arm. But they, similar to some of the prior studies, they noticed worsening MARD during the activity. So if you look at the abdomen versus the arm, 16.5 versus 15.2. So really the arm performed a little bit better. But the one thing that I noticed about all these studies is much like a nightclub, there is no kids anywhere around. There was a couple studies that reported some things at summer camp, but those were all during like meal times when they were not actually being physically active. So there was no kids studies. So what we did was we wanted to investigate the accuracy of the factory calibrated CGMs during physical activity in the youth. You know, did they perform better, worse? How was it? What we did is we enrolled 30 participants who were using a Dexcom G6. We initially said, oh, we'll take all comers with a factory calibrated, so Libre 2 as well. But we just don't have that many patients using Libre 2 in our clinic. We have a lot more Dexcom G6s, so that was everybody we got. They had to be over 13 or at least 13 years of age, have a type 1 diagnosis of at least 2 years, trying to kind of eliminate that honeymoon phase. And then do something for their diabetes. By no means did they have to have perfect control, but at least an A1C under 10. I don't want you to come in and have large ketones and then me get you on a treadmill. Also, we had them get onto a in-body machine, which does a body composition measurement and tells you about their weight, their BMI, their body fat, lean body mass, skeletal muscle mass, as well as the resting heart rate. So then we use that resting heart rate to calculate what their heart rate reserve would be. So then we could calculate what would be moderate intensity activity for them. And our goal was to keep them in a moderate intensity activity based off this heart rate reserve during their exercise of 40 minutes on a treadmill. At minute 20, we had them take a break, which was halfway, and we took a 10-minute break at that point. We wanted to emulate kind of like a soccer match or a basketball game that many of the youths would be participating in. And then we obtained paired Dexcom values along with the Contour Next glucometer. We use the Contour Next as previous studies have shown that it's actually one of the most accurate ones in comparison to the gold standard of a YSI. So we grabbed these paired measurements a little bit before, so 25 plus or 10 minutes prior to the exercise, right at the beginning of exercise, and then every 10 minutes while they were exercising for that 40 minutes plus the 10-minute break, and then for 20 minutes after exercise as well, just to make sure we weren't sending them out the door like, hey, you're having hypoglycemia, see you later. So we grabbed all these values. And then we did a statistical analysis looking at what the MARD was, the mean absolute relative difference. We also plotted it on a Clark error grid, which if no one's seen that before, I'll kind of explain what it is and how we look at that. And then we did subset analysis based off the CGM location using a gamma generalized linear mixed effects model. The gamma because it isn't evenly distributed like a bell shape, so you got to shift it to one side. And then we did a regression analysis using the abdomen as our reference category. So looking at our patient demographics, as I mentioned, we enrolled 30 participants. One participant withdrew while they were running on the treadmill. They said, this is too much for me, I don't want to do this anymore. So we only had 29 patients actually finish the study. One of them actually had sensor failures during 3 of their readings. So we missed out on the opportunity for those, but otherwise had a full data set for that individual, which was included with the other 28 individuals for the full data set. As you can see, the mean age was about 14 and a half, with a pretty even distribution on gender. Most of our patients were using a pump. You can see it was 86%. And then, of that 86%, it was 48% of those were using Tandem, with most of them using Control-IQ as well. And then the A1C, even though we were saying less than 10, ended up being 7.6, which is actually pretty decent control for our teenagers. Then we also, as I mentioned, substratified based off the CGM location, presented to the right. And I have the abdomen and the buttocks highlighted there because, remember, those are the two FDA-approved locations for the Dexcom G6. So as a reminder, this is that study that I talked about before. If you do aerobic exercise, you would expect there be a big decline in what your blood sugar would be. So in this paper by Yardley and colleagues, it went from about 170 down to a little below 120 when they did the aerobic. And this was that study that compared doing aerobic and then resistance exercise versus doing resistance exercise and then aerobic. So again, it wasn't surprising with some of those other studies that looked at resistance that there wasn't a huge change in the MARD because you weren't having a whole lot of changes in your blood sugar at all. So similar to their results, our patients had a decrease in their blood sugar. This should look fairly similar. It probably looks like that AGP printout that you get for your Dexcom. This is the median line, kind of coming down from. Ours is fairly similar, about 170, and on our median at the end of the exercise, which is time 50 here. You can't see my pointer, can you? No, you can't. There we go, time 50. Went down to about 100. And then the 25th and 75th, this works. Yeah, hey. The 25th and 75th are represented by this shaded blue, and then the 10th and the 90th are the green dotted as well. So we had some individuals that were having some hypoglycemia here towards the end of exercise. Looking at how this looked, the change in MARD over time, we noticed that we started at about 15%, which was consistent prior to us starting exercise and then right when we started exercise. But then as the exercise continued, the MARD rose during that time. And then we took a break between minute 20 and minute 30, at which point the MARD improved again from, mid-20s down to the high teens again. But then when exercise resumed again, it proceeded to climb all the way up to a peak of 33%. And then again, after the exercise was stopped, the MARD improved within 10 minutes afterwards. So it started at about 15%, actually decreased down to 14%, but then more than doubled up to 33% at the end of the exercise session. Absolutely. So the CGM readings were almost consistently higher than the capillary glucose. And it wasn't plasma, so we weren't drawing venous samples. We weren't taking YSI. It was with the finger sticks. Stay tuned. So this is a Clark error grid. Many of us have probably seen this before. The reference value, so in this case, the glucometer value is referenced on the x-axis, and then the CGM value is plotted on the y-axis. So as we were just talking about, many of them overestimated the CGM value, so kind of on the upper end of this middle line. As a reminder, for those of us who may not be as familiar, zone A represents glucose values that deviate by less than 20% from each other and are low when your blood sugar is low. So when it's less than 70, you're also less than 70, which is this little box down here. So you can see we had a couple values that sat there. Zone B, so a little bit further out here, represents values that deviate by more than 20%, but would lead to either benign or no erroneous treatment. So, yeah, your blood sugar is running a little high here, and you're probably going to give some insulin. So it's not far enough off to where you're going to give too much insulin and end up giving way too much. Or, down in this area, oh yeah, your blood sugar is running a little low here. If you eat something, you're not going to end up with a blood sugar that's 300 after you exercise because you erroneously treated. However, you notice that there's a few values over here in zone D as well, and that's representative of a dangerous failure to detect and treat zone. So if you look at that, for the reference, it's less than 70. All these values are less than 70, but they're saying that they are not less than 70 on your CGM. So this entire cluster here are saying, oh goodness, you're up 100, more than 100, in the 90s here. So you're not having someone stop the exercise like they should and treat their low blood sugar at this point. You're letting them continue. This is looking at what the Clark error zones did over time, just kind of from each one, because the previous plot was all the times. So if you look, the blue is representative of zone A, which remember is within 20%. B is the orange or yellow, and then zone D is red in color. If you notice at the beginning, wow, we got a high percentage that are within 20%, a high percentage that are in zone A. But as you continue through exercise, that zone A starts to dissipate and go away. It does improve slightly here during rest, but continues to decrease all the way from 79% down to 34%. And that's mostly replaced with values from zone B, so greater than 20%, but no erroneous treatment, from 21% to 45%. But you also notice that at the end of the exercise period, at time 50, so at the end of the 40 minutes of exercise, you had 21% of the values were in that dangerous failure to detect zone D. So that made us wonder, well, goodness, what is going on here? Why is this happening? So we then said, okay, we're kind of noticing a trend that when people wear it on a certain location, that maybe there's a little bit of a difference. So we did a subset analysis based off of CGM location. Remember, our CGM locations are mentioned up here. Something I didn't mention earlier is there was an even distribution between abdomen and arm, a few more on the buttocks, and very few that were on the thigh. And because the thigh only ended up having 2 individuals, we actually excluded that from our analysis because there wasn't enough data points. So if you look at a CGM being worn on the buttocks, you notice that it starts off with a worse MARD than just your all, like if we take all comers. Starts off worse, and the peak is far worse than what it was. So it went from about 18% all the way up to a 46% MARD, which is pretty impressive. In opposition, if you wore it on your abdomen, you actually had an improvement in MARD initially, and then it only got up to a maximum, and this was after exercise was completed, of 18%. So it changed from 14% here to 18%, which was not a large change. Now, if we look at it on the arm, it actually seems to mimic the all. So it's just kind of an average of both of those. Went from about 13% here up to 36%. So not great, but still wasn't nearly as bad as the buttocks. Now, we're going to get to the question that was asked earlier is, was there a lag time? Did we notice something there? So if you look at all the data points, don't substratify it, you notice that we start our lag here at time 10, comparing the CGM at time 0 to what it was, or looking at the CGM at time 10 to what the glucose was at time 0, right? And then going on forward. The CGM from time 20 to what the glucose was via fingerstick at time 10. And you notice the MARD is not nearly as pronounced if you adjust for that 10-minute lag time. It goes from about a 14% here, only up to a 22% for all takers. That's pretty good improvement. If you look at that for wearing it on the abdomen, goodness gracious, it's less than 10% at the start here, and only goes up to about a 14 or 13% during the exercise as well, and stays right around there as well. That's fantastic results. Even if you look at it for the buttocks, which didn't perform as well, it still did not have as much of a change. You started off at around that 16% or 18% again, but only increased up to 31% at 10 minutes after your exercise was completed. So it appears that there may be around a 10-minute lag time, or that would certainly improve it. However, looking at real-time data, because we can't necessarily say, oh yes, this is what my glucose is in 10 minutes, these are the graphs that we got, and it shows that the buttocks location may not be the optimal location to wear your CGM if you're going to do exercise on the treadmill. So we then broke that down looking at the Clark error zone grids. So looking at the abdomen, you notice there's a lot that are hanging out in zone A here. Pretty good performance. Arms showed similar, but as you might expect, just based off of the MARD, there was some that were kind of hanging out here in zone B, overestimating what the glucose was when you were using the CGM. Thigh, I will put in here just to have it. Not a whole lot of data points, but we're kind of scattered all over the place. Oop. But then the buttocks, you notice they are scattered all over the place, and that is where all of those that were in zone D came from. It was from patients wearing it on their buttocks. Comparing that to the two FDA-approved locations, abdomen to buttocks, pretty striking that when you wear it on the abdomen, you have a much better performance based off the Clark error zone grid than you do on the buttocks. Statistically speaking, if you look at the logistical regression analysis, it showed a decreased odds of attaining zone A under the Clark error grid when the CGM was placed on the buttocks with an odds ratio of 0.146, which is pretty darn significant with a P of 0.003 with a 95% confidence compared to abdominal placement. So that raised maybe a few more questions than answers. So what's going on? Why is this happening? So that made me look at an additional literature review of what's different here. Remember that CGM measurements come from the interstitial fluid, not from capillary glucose measurements. And several articles have actually reviewed that there are interstitial fluid changes and shifts, particularly during exercise, that can cause a gap between what the glucose measurement is in that interstitial fluid and what it is via capillary measurement. We'll talk about that just a little bit more, but it does make you wonder, for someone that is running on a treadmill or walking on a treadmill, they're mainly using their legs and their butt. They are not using their abdomen very much. They might be using their arms a little bit, kind of moving along here, but mainly it's going to be your legs. Is that what's contributing to that wide variation in the MARD in comparison to the abdomen, and why maybe the arms, which are kind of intermittently used and not used quite as much as the buttocks, but not as minimally used as your abdomen, maybe is not as affected as much, but more than the abdomen? So our study does have some considerations that you need to make, though. First of all, we didn't control for insulin or carbohydrates that were taken before the exercise. So there was some pretty big swings in what your blood sugar was. However, that's real life. I mean, having some of the other studies that I looked at, they were controlling for all that. It was, you have to eat at this time. You eat this many carbs, you take your insulin, and then you're not going to exercise for 3 hours afterwards. That's great. But as someone that lives with diabetes, that's not real life. Like, I've got 2 kids at home. I'm lucky if I can figure out how to get exercise in most nights. And if it is, it's, oh, I just took my dinner bolus. I hope that I can keep my blood sugar up because I can't control for all that. So this is a more real life emulation. However, we did have to have them on a treadmill. We didn't let them go and play soccer or play their basketball games, do their cheerleading, or just regular generalized play. So it may limit the generalizability to those mixed activity sports. We also had a homogeneous patient population with fairly well-controlled diabetes. I mean, the A1C was 7.6. We'd love all of our patients to be like right there, be a primo. So it may not be generalizable to all patient populations as well. And lastly, and this is important, we only used the Dexcom G6. So this may not be applicable to the Libre. This may not be applicable to the Eversense. But considering the Dexcom G6 is the one that's most widely used and integrated with those closed loop technologies where it's making adjustments based off of what the glucose is, I think it was really important to look at that. So some of our conclusions. The MARD increased during exercise according to our study. It did improve when you were taking a break or after exercise. It seems like the location of the CGM may alter the accuracy as well, maybe due to those interstitial fluid changes. But we may need to do additional research to truly support this theory. So should we not use CGM during exercise? I would say that would be a poor choice. I think that continuing to use CGM during exercise is extremely beneficial because, like I said before, carrying around a glucometer while you're running is not exactly easy. However, you may want to set a higher threshold for detecting low blood sugars and confirming with a capillary glucose stick. You also may want to ensure that you're following aero trends to see, oh, am I expecting to go low sometime very soon, which may help predict and prevent hypoglycemia from occurring, which you probably wouldn't be able to do if you were just doing glucometer testing and not looking at your CGM at all. So again, this is I think this was reviewed actually by Dr. Thrasher when he gave his chat a few months ago. This was a paper by Moser, Riddle, and colleagues that looked at and gave recommendations of what you should do based off your CGM reading, where your glucose is, and what the aerobe is doing, and what you should do with exercise. So kind of quickly going over these. If your blood sugar is high, greater than 270, and you got high ketones, don't exercise. Not a good idea. Give yourself some insulin. Figure out why you got high ketones, and don't do it because you can worsen your ketosis. But as I talked about in my last lecture, even if your blood sugar is high and you have more minimal ketones, you can go ahead and proceed with exercise. You might want to give yourself a little bit of insulin, but you can go ahead and do it no matter where your arrows are going. Then they start substratifying things based off of your risk for hypoglycemia. So low risk is this left, moderate risk is the middle, and high hypoglycemia risk is over here on the right. So, in the world of peds, you might think, oh goodness, you've got a high hypoglycemia risk, and you might not notice it in those toddler age kids, 2 to 5, something like that. Or some of that is hypoglycemia unawareness, right? So all of these say you can continue to proceed with exercise. The only difference is if you're expecting an increase in your sensor glucose and you're already either going up or you're stable, you may want to give yourself a little bit of insulin depending on these set ranges. So high 100s to high 200s, 200s, or 200s. This green one is if you're in what I'm going to say is kind of the acceptable range. Hey, you're good to exercise. No matter what your arrows are, you just go ahead and proceed with your exercise. So anywhere between like 120 to 180, 140 to 200, and then 160 to around 220. It's not exactly what it says there, but I'm sure you guys can read at this point. Looking over here is where things start getting a little bit more complicated. If your blood sugar is less than 126, but your blood sugar is going up, it says go ahead and proceed with exercise. However, if it's either stable, going down, or really going down, you need to eat a different amount of carbohydrates based on whether you're expecting an increase in your sensor glucose reading, so whether you maybe ate something a little bit before, or whether you're expecting to go down. And it just varies by how many grams of carbohydrates you take. Then, this is for adults. If you're less than 70, it says stop, confirm with a finger stick, and take some carbohydrates based off of what you would normally do. Then, after you do that, you can restart your exercise. If you're below 54, stop, don't pass go, don't collect $200, don't restart exercise, just treat and hang out on the sidelines. It's a little bit different for kids. Kids, they use a higher threshold, which I appreciate, particularly based off of the research I just presented. They use a threshold of 90 to say, you should probably stop exercising and get some carbohydrates in. Additionally, the other big change that they made was the amount of carbohydrates, because anybody in our practice knows that when our kids end up treating their low blood sugars, they end up on a roller coaster ride. They go down and then they're 300 an hour later. So they're trying to say, hey, limit it a little bit, 5 to 10 grams, 10 to 15, or 15 to 20. And with that, I have presented my research. These are my references. And the all-important event code is now listed on there, which I'm sure Kelly has also put in the chat. I'm definitely available for any questions. Thank you.
So each of the kids did only.
Correct. It was just one session of exercise for each one of the participants. We didn't have them come back multiple times.
So if there are variations.
We wouldn't know at this point, correct.
And were there a lot of variations?
There was some pretty significant differences, but a lot of that was based off of where they were wearing their CGM, which is why we tried to substratify it based off of where they were wearing those CGMs, because it was difficult to predict until I was like, goodness, it seems like every single time somebody comes in with a CGM that's on their butt, they end up low eventually, and the CGM didn't know about it. So that's why we ended up trying to do some of that substratification.
For those who were in the D, did you see if those were the ones a rapid decline in blood sugar? They have a larger.
Yes, many of them did have a more significant drop or a more precipitous drop in blood glucose, but there was also a lot of other individuals that had pretty precipitous drops in their glucose that didn't end up in zone D, particularly the ones that were wearing it on their abdomen.
Do an analysis. Sugar.
We did not do that analysis. No, we didn't do an analysis looking at changing glucose versus Clark error grid or whether they were going to be in zone D. No, we did not.
Did those zone D people?
Yes, there was a couple of kids that were like, goodness, I'm starting to feel low. And we asked them whether they wanted to stop. And most of them were like, nah, I'm good to go. We'll keep on going. But we would check them and make sure that they weren't low. And if they were below 70, they'd stop and have to sit out during that time. Yeah, there was some. 50%, I know. Correct, yeah. 45% of them were control IQs. Yeah, like 45% of all the participants were on control IQ. And we had them start exercise mode before they started as well.
I saw that Omnipod was minimal
There was, I don't think we had any Medtronics, honestly. Yeah, we had no Medtronic. Yeah, no, it was just Omnipods and Tandem, which is very similar to our patient population. We have very few that are on Medtronics at this point. I didn't do a breakout between Aeros versus the other Omnipod, which is, Dash.
Omnipod is your loop, right? And
Correct.
Control IQ. Those were the two. I know you didn't have a large number, but it would be interesting to see take homes.
So I did kind of like a back of the paper napkin. I didn't send it to Yana for statistical analysis, but just kind of like looking at what the difference in MARDs were between different pumps. I didn't notice a big difference between them. It was similar.
Dexcom.
Correct. Yeah. Everyone was using a Dexcom.
But
Yeah.
having a loop in a little bit different.
It didn't seem to make a big difference, to tell you the truth. And that may have been because we weren't controlling for the amount of insulin they had on board before they started exercising. So, we recorded when they took their last insulin and how much they took. So we could have calculated, hey, using degradation, this is how much insulin on board you had. But again, doing like a back of the napkin calculations and looking at it on my Excel spreadsheet, I didn't notice big differences based off of how far before you had your last bolus and the Clark error grid analysis of like zone D versus not.
Stop sharing.
Oh, yeah, I'm actually looking at a few of them. Let's see. I think Dr. Girish is going to have an excellent question for me. I think I saw it. Group review of CGM, how much the glucose in sweat during exercise influence the CGM in different part of the body? It's an excellent question, and I do not have an answer for you. Glucose in sweat during exercise influences the CGM in the different part of the body. I have no idea. That's a great question.
But isn't the sweat is not going to be in the sweat glands?
I agree, but I have no idea whether, you're sweating underneath your CGM. Does some of it leak down into there? I have no idea. I wouldn't guess so because it's supposed to be reading interstitial fluid, but possibly. Don't know. Yeah, and that was one of the reasons why we did that in-body measurement, was to try and kind of like gauge, are these kids really well hydrated or really poorly hydrated? And we didn't notice a whole lot of differences on any of those. Like trying to, again, looking at my Excel spreadsheet, I tried to break it down by all those things, and I was like, I'm just not seeing anything here except for where your CGM is located.
So one of the arguments is interstitial glucose is what the tissues, not the blood glucose. Correct?
Ask your question again?
Interstitial glucose is what the tissues are seeing. They're not seeing what's in the blood.
Correct. Yeah,
right?
it takes a little while for the gradient to happen.
Correct. So the reality, the blood glucose is the error. Because I'm measuring something that's not being seen yet by the tissues. Now, tissues are seeing something different.
So I guess.
So like one of the things, although it's a lot of time gap difference, one of the reasons for why if I drink something and my blood sugar goes up, I'm not still feeling it now, is how you sense the glucose. But also the glucose has to still go into your tissues and fix it.
Yeah, absolutely. And I guess the question that was raised to me was, is the actively exercising muscle different than everywhere else? Because, the capillary glucose measurements, and then obviously the most important portion is providing glucose to the brain, right? I don't really care that much about your glucose in your muscles. If you're getting fatigued, sucks, but, I care about what's going up to the brain. So the fact that it seemed to be lagging behind here, so you wouldn't identify that your blood sugar is lower, that's being provided to the brain just kind of made me go, oh, goodness, do we need to be more worried about what we're seeing on the CGM measurements, particularly if you're looking at it on the actively exercising muscle. But again, I don't have a different type of exercise. Like I didn't have people do crunches or, do yoga to like really engage their core and see if maybe I can make the abdomen really bad in comparison to the arm, which hopefully wouldn't be used quite as much, even though yoga seems like an absolute sweat fest to me whenever I try and do it. That there didn't seem to be any difference in the MARD or Clark error zones between the different sexes. I looked at that as well. 13 and older, we're trying to get people, that at least it started puberty.
So,
I didn't do a pubertal exam, but, unless you have delayed, probably have started by then.
and you said you hadn't kind of,
No, it was whenever they were available for exercise. So some of them were first thing in the morning, like 8 in the morning. Some of them, I think the latest one we did was like 2 in the afternoon, because really between like consenting them and getting them all in.
mealtime versus
Yeah, and we didn't control for any of that. We wanted it to be free living conditions. Like you eat whenever you want to, you take your insulin when you want to. If you ate 3 hours ago and you miscounted your carbs and your blood sugar was 300 right before you came in to see us and you were like, oh my goodness, I need to give myself insulin, I didn't control for that. So there was a more precipitous drop in glucose, but again, that's real life conditions. That's not us trying to manipulate some in lab or try to make really set things. We're trying to emulate what these kids are doing in a day-to-day life.
So based on these things, was there a pattern? Is there a program that I can write, saying, use this built into the Dexcom on an exercise mode?
A correction for what the glucose is reading, probably with a much larger data set, you might be able to do something like that. Or what exercise mode does is sets a higher threshold, which is exactly kind of what we're recommending to stop the insulin. But I think it also needs to probably alert you
at the end of the day,
even more.
Even the reading that it gives is a corrected reading. That's
Correct. Yeah,
it's giving a calculation based on.
Yeah, correct.
But
yeah.
It may be possible. So, light exercise, walking.
Well, and again, if it matters whether you're actively using that muscle or not, on what that calculation would be, that algorithm would need to do, that'd be really tough to, first of all, make, second of all, get through FDA, third of all, teach users to use. Goodness gracious, if I'm doing an upper body lifting exercise, but it's on my bicep or my tricep, but I'm doing bicep curls, does that matter? I'm not actively using my tricep necessarily, but it's close. So it's just interesting. Additionally, that's more resistance exercise versus aerobic. So I think all those it would be very difficult to make that. I'm not saying it'd be impossible, but there'd be a lot of variables. I did not submit it to the tech conference next week. It's going to be presented at Pediatric Endocrine Society, and then we are targeting a different journal.
Other questions?
I didn't see any more. Nope. I think I had answered Dr. Folsom one about will you use your results to advise patients moving forward in regards to CGM placement during exercise or include finger stick activity. I think that if you're doing something that's using your legs, just be more careful, set higher thresholds, as I mentioned.
10 days of, 10 days.
Yeah, absolutely, right?
Every time you change your next.
I think at the end of the day,
I just remember the first time when I went. That it's like a plasma.